All right, I got a green signal from the planning people that we are ready to begin. I am really excited to speak about the importance of palliative care today. My name is Prabhakar. I am Assistant Professor of Medicine at Hopkins University School of Medicine, and over past 2 decades, I have had the privilege of practicing palliative medicine in direct clinical care. And today, we are going to speak about the changing reality of palliative care in India from margins to mainstream healthcare. We have panelists who are going to bring together important perspectives from global experts and policymakers to discuss how palliative care is transitioning from a neglected service to an essential part of mainstream healthcare in India. The session will explore health system integration, community-based care models, innovations in service delivery, and policy reforms required to ensure equitable access to palliative care. For those of you who may not be aware of palliative care, it is a type of care which is delivered to seriously ill patients and their families to improve their quality of life. It is provided by physicians, nurses, interdisciplinary team, including counselors, social worker, chaplains, and community healthcare workers. And to begin, I am excited that Uma ma'am is here. Mahadevan, she's Additional Chief Secretary and Development Commissioner of Government of Karnataka in India, and she's an Indian Administrative Officer currently serving as Additional Chief Secretary with Panchayati Raj in the Government of Karnataka. She joined civil service with All India Rank 2, and she has written widely on development issues. I had the privilege of having a conversation with Uma ma'am a few minutes ago, and I'm moved by how she brings humility and care for humanity in the important work that she does. And I want to invite her to give her opening remarks. Uma ma'am.
Thanks so much. And it's wonderful to be here from Karnataka, where we are now trying to reach a new stage of trying to bring palliative care to all communities and all households that need them. It's also wonderful to be here with very outstanding panelists, including Dr. Rajagopal, who I think is a guide to all of us in the work that you've done, sir, in Kerala, and that you continue to lead in different parts of the world wherever it's needed. It's thanks to you, too, that the Government of India launched the National Program for Palliative Care, which Karnataka has adopted and which is taking it forward. Palliative care, very briefly, in Karnataka, I have some numbers. We have palliative care units in all district hospitals under the NHM. We have facility-based care and home-based care services also made operational. We have human resources in terms of 2 physicians, 8 staff nurses, 2 multi-purpose workers per unit. And there are some numbers of the kind of staff that we have. More importantly, more recently, the legal frameworks, including the Supreme Court judgment, relating to end-of-life care, such as advanced medical directives and protocol for withdrawing life-sustaining treatment have been introduced. And it's an important milestone that not only the advanced medical directives, the processes for advanced medical directives have been put in place, but also the first advanced medical directive under this process has been deposited. And the gentleman whose AMD was has had the right to a dignified end to his life. We have also introduced a mechanism for the recognition and distribution of essential drugs, still putting that in place. the Narcotic Drugs and Psychotropic Substances Act in India was amended several years ago, and the rules were amended, but many states have to take consequential steps and remove this from the control of Excise Department, which has taken some time. We have done it in Karnataka, Excise Department. I was just sharing with my co-panelists that circulars have been issued for removing it from excise, which therefore makes it easier for hospitals to obtain pain management medication for the treatment of their patients. Despite all of these steps, there are still many, many miles to go. We do have challenges. Palliative care is still seen as a frill, so to speak, in health systems which are extensively and deeply focused on maternal mortality, child health, and so on. But I think we need to make the space for it, and we need to put systems in place. We need more awareness and acceptance among healthcare providers themselves and also among the public about palliative care services. Because right now we often have late referrals or neglect of such services. Patients don't know about their rights. Remote and rural regions lack access. Pain management barriers, access to morphine and other medical treatment is inconsistent because of supply chain issues, inadequate integration with other programs like NCD, mental health, geriatric care, and limited data on utilization. The way forward, I'm happy to say that with the help and guidance of Pallium India, we in Karnataka have just initiated a pilot in a cluster of 7 Gram Panchayats. Now, why Gram Panchayats? Gram Panchayats are rural local bodies, and I'd just briefly like to say why we're interested in doing this through local bodies, because all of what I've told you just now is from a vertically managed health system. But it's our belief that palliative care, if it has to reach every person, we should not use the approach of the last mile, which is a metaphor from telecommunication, where every person where they are reached at their last mile of a vertically managed system. But what we saw during the COVID pandemic was that rural local bodies really came forward to help people with all their needs wherever they were and regarded them at the first mile. And that's an important, not just a semantic difference, but it's an important difference in how we provide services to people. We saw during the COVID pandemic, Gram Panchayats task forces coming together, elected bodies with officials and field functionaries like ASHA workers, Anganwadi workers, and other frontline workers, coming together to serve remote rural communities and households with whatever needs they had, including TB medicines, HIV medicines, milk for babies, antenatal care for pregnant women, all of that during the pandemic. And this is exactly the approach that, happy to say that there's a team from Hopkins which is actually studying this. We hope to take forward this approach, not only during the pandemic, but to provide first mile services and services to households, regarding them first mile, meaning that every family and every household should have their individual plan, their individual access. This is a way in which we can address social determinants, whether it's housing, whether it's nutrition, for TB patients. All the research is already there, but how we provide the services can only happen through this convergent governance structure, which is the task force, or rural task force, in every local body with tight funds, which will enable them to provide services such as transport or access to diagnosis or treatment, whatever it is. And so I'm happy to say that this is exactly what we've started in 7 local bodies in Karnataka, which are with the guidance of Pallium India. But now we're talking to civil society organizations and philanthropy to see if we can take this forward in all the 6,000 rural local bodies of Karnataka. This is an exciting moment for us. I won't say more, but it's something we're doing.
Thank you very much, Uma ma'am, for these important words and the exciting work in the field of palliative care, which is happening in Karnataka. I want to move to Dr. M.R. Rajagopal. Dr. Rajagopal, you are pioneer advocate for the right to pain relief. You are the founder of palliative medicine, Pallium India in Kerala, and are known as the father of palliative medicine in India. I am privileged that you have joined this discussion today. What are the critical reforms still needed in India's drug regulation and health policy? And I also want to invite you to speak about the important work of palliative care that you are doing.
Avani, thank you very much. I'll start by paying respect to the real father of palliative care in India, Dr. Lucito D'Souza in Mumbai, who founded the Shanti Avedana Southern at a time when I had not even heard the word palliative care. Thank you for the introduction. And if I'm an advocate, it's not only for pain relief, it would be for the mitigation of needless, serious health-related suffering, pain, other symptoms, psychosocial, spiritual, everything. Crucial reforms that I would want. As soon as Uma Mahadevan Madam becomes Principal Secretary of Health in Delhi, or when she accompanies me to meet the Principal Secretary of Health, I know what all I want. I realize that palliative care cannot stand alone, and that's not what we want. Eventually, our objective is integration of palliative care into healthcare. And therefore, we'll want some drastic steps taken by her on health. Now, India spends 1.3% of GDP on health. Any civilized country spends at least 5%. I know that the structure will have to be built gradually, but certainly our grandmothers taught us that health was more important than wealth. We have to spend more on health. And as we do that, one major change as all the extra money that comes in from the GDP, I would want spend on strengthening public health systems. It's not impossible. See, Tamil Nadu, Kerala, Himachal Pradesh, all have reasonably robust healthcare systems. Nothing compared to USA or any other high-income country, but not bad at all. And that is what we want to replicate. Because unless the person there gets care from the government system with all its weaknesses, we have seen what happens with the insurance system. Patchy, partial, and much too often exploitation, I must admit. Then, Madam mentioned a national program for palliative care. Now, there are two things happening. We have the national program of palliative care, where some funding is given to states on an annual basis. Karnataka cannot plan ahead to the next years based on what NPPC may offer. Now, there's another development, positive development. I shouldn't be moaning about problems all the time. The National Health Policy of 2017 includes palliative care at the primary level. The National Program for Palliative Care has palliative care at the tertiary, secondary, and primary level, but implemented only in the secondary and primary level. These two have to be merged. One or two meetings in Delhi may actually create an implementation framework for using the available resources rationally, instead of not just sprinkling it rather irrationally all around. Avani, you mentioned particularly pain relief and opioid policy. So Indian Parliament, after 19 years of efforts by the whole palliative care fraternity, Indian Parliament amended its Narcotic Drugs and Psychotropic Substances Act in 2014. The next year, the relevant rules were published. They are in force. Unfortunately, when the rules came out, there were several problems and more hard work. And by 2017, a draft revised rules were passed. This is not complicated. It does not have to go to Parliament. Just one government order from the Department of Revenue is all that it takes to revise that NDPS rules, so that all the irrational parts are corrected. Unfortunately, that's being held up. So if Uma Madam has a friend who is a Revenue Secretary, this is what we will do next. Go to North Block and get this done. It's fairly simple. Only thing is we have not been able to reach the right person. I would also boast to everyone about what has been achieved on the education front, again, by joint advocacy by the palliative care fraternity. The undergraduate medical education includes palliative care now. 18 modules under 12 themes. It's already in. Then nursing curriculum subsequently from 2022 also now includes palliative care. Isn't that phenomenal? We have the policy, we have the available access to essential medicines, and then the education comes in. If implemented properly, if we can fill the implementation gap, we have got it done. Currently, our organization is conducting faculty development programs because of the more than 670 medical colleges in the country, only around 40 have any palliative care. So who is going to teach all this? So we are getting interested faculty from these colleges and training them. We are also entering into have 3 MOUs with 3 health universities and working with them also to make this happen. All in all, a rosy picture if the implementation gap is filled in all 3 sides of the triangle: policy, education, and access to essential medicines. Thank you.
Thank you, Dr. Rajagopal. I just reflect back on something that was said in an earlier section, that there is nothing better than an idea whose time has come. And what I'm hearing from you, that the time is right. There is a felt need by the community, and there are systems in place now to move this forward to implementation and integration. I move to you, Dr. Carolin Elizabeth George. You are head of community health palliative care and research at Bangalore Baptist Hospital. I am delighted that you have joined here from Bangalore. And my question to you is, what role can faith-based mission hospitals play in bridging service gaps in underserved regions? I was really moved by the stories that you have shared about the grassroots directly to patients living in rural community work that you have done, and I invite you to share this with our audience.
Thank you for the opportunity, and I'm so privileged and honored to be at this gathering. So, coming to the question, when we are doing the palliative care in the rural Karnataka, we have a hospital in the city, but that palliative care work started 3 decades ago, even before the oncology started. That's because we are a Christian missionary hospital, and then we saw patients in the really last stage of cancer, and there was nobody, everybody was saying that we don't know what to do. And because of that, our palliative care program started. At that time, it was in the hospital and extending to the patients who were coming there. We also later have a community outreach program where we thought in the rural Bangalore, that is Bangalore rural district, what are the type of patients that we see at that time. We found that patients have no access to palliative care. They are seen at the last stage of cancer with no diagnosis, covered with maggots, because the skin is being affected and no treatment. So it's like you can see worms and things like that. And family doesn't know what to do because they're kept at a different room sometimes, just outside the house. They want to help, but for them to take them to any hospital will be 50 kilometers or 100 kilometers, and some of them have pain that needs to be addressed by medications, oral and sometimes IV. And every fourth hourly to get these medications and taking them to setups where palliative care is offered was actually, there was no setup. So we thought, how do we start our journey? Because you need to reach out to patients in the rural areas. We started our journey, we don't have funds, so with one doctor and a nurse going in an auto rickshaw, 80 kilometers, 100 kilometers. But where do you see these patients? There's no repository. Where in a village you reach, how do you know where the patients are? There's no way you can. So you actually, as ma'am was saying, in the Panchayati Raj, we go to the Panchayat development officers and ask, like, you have a card saying this patient like this, is there anybody like that? So they would say, yes, there is in this room. So the first when you go there as a team, people used to say, don't come there because there's a stigma. They say that, a medical team from the city is coming. Why are they coming? Is there something problematic in some marriages? Something is getting affected because, it may spread to somebody. So we were told that you have to stop your van, like your auto late, carrying so that you go. And so these were our early stages. We started in 2015 to rural outreach, and a family from philanthropy from US, Korean Foundation, actually extended to help us with the program. There we actually started covering with village after village. We go, our field workers go and say, like in a day, we will cover 5 villages. And we say that this is palliative care. Do you have any patients like that? And at first, they were all even scared to refer patients, saying that, would you charge? Because they're not at that moment of time, they're not productive. They're like bedridden, and other people are going for 1 or 2 people at home, they have to go for work. So there's no dispensable income if a team of doctors and a medical team come and actually serve them. They were scared, like, we'll be asked money. And how do you say that we don't have money? It's a dignity issue. So we said, no, we would extend it free of charge. And we used to then, go by creating this ecosystem in terms of where the PBOs and the milk federation in Karnataka, everybody comes for the milk. There, they used to refer patients saying that there are 3 patients. So we used to go and visit them. And I must say, like now we extended to 3.5 million population that Bangalore rural and Chikballapur districts. We have 5 teams which go out. And one of the things that we again see is patients who are actually in the rural areas. They don't have any other, like Kerala, there's volunteers. Here, we tried volunteers, but it was not working because everybody has to go for work. But we actually, the family, we recruited family, we put subcutaneous lines, we taught them how to give early injections and things like that. And people who are illiterate, they were able to do it actually without any errors. And, and they say that everybody in the family slept nicely because that is the first time they have no pain. So imagine your parent or your child having cancer and then pain and they're howling, and you as a mother has to hear it and then staying together. So that's tough. So like us, many mission hospitals, their access to communities where there is trust and their access to marginalized communities. Also, we also we have a trust. It's a very complicated dynamics talking about death, talking about, not able to take to the hospital and things like that. So platelet organizations actually bridge a lot of things, and also they work with low resources. So they actually recruit people like their families there or the community around it, because you have to work with what you have. So in those areas, I think that's the contribution that we can do.
Thank you very much for sharing such inspiring stories and practicing palliative medicine. Many times the compliment that I would get as a physician is that you are a chaplain or a social worker who just happen to go to medical school. And I think we need more inspired, sensitized, faith-based or spiritually based people who are pursuing palliative medicine and serve the society. And you bringing this from faith-based organization is such important work that you do. Thank you. I move to you, Sweety Thomas. You are Chief of Staff at Ajit Foundation. And my question to you is, from the philanthropic objective perspective, what has shaped Ajit Foundation's interest in palliative care, and why this is important from your perspective, and what kind of collaborations excite you, especially between various stakeholders, including funders, researchers, and local healthcare systems? I invite your voice, quickly.
Thank you so much, Dr. Avani, and it's absolutely great to have so many people come together from different walks of life on this panel, and I really would like to extend my sincere thanks for everyone who has made time to come for this. Just to give you a background of AIF, the Ajit Isaac Foundation is a domestic philanthropic foundation. What that really means, I know Uma Madam talked about the role of government. Dr. Carol and Dr. Rajagopal have talked about the role that both CSOs and hospitals are playing. For us as a philanthropic foundation and as a private philanthropic foundation, what it really means is that we become the risk capital for very underserved social causes. And that's exactly what palliative care today is in India. On the other hand, Ajit as a person is a first generation entrepreneur who has a passion for building things from scratch. And that's what has happened in his business, and it's very strongly reflected in his philanthropy. So even though the idea for us germinated by the lived experience of the founder of the foundation, as we've walked down this path, what we've realized that in a country that is pegged to grow older and have a very high disease burden, palliative care has a key role to play. Accessible palliative care can truly help us in optimizing what is today a very overburdened healthcare system. And on the other hand, it has a strong economic impact, because we know that most families, even middle class families, exhaust their life savings in unnecessary treatments, in treatments that are excessively expensive, because most of the time healthcare is an out-of-pocket expense for a country where a large population is not covered by insurance. And as funders, what we are hoping is that we are going to be like, what we are able to do is demonstrate models that are cost effective, that are more humane, and that are that are more workable. What we also need to be able to do for the funder community, I feel, is to think through how do we capture and articulate the impact of philanthropic capital in palliative care. And that's what is going to be able to motivate other people to kind of also put capital in this extremely niche. We've heard this word so much when we've talked to other organizations who are in this space, niche, underserved. But it's, as you said, Dr. Avani, the time has come to make it mainstream. There's enough money that goes into healthcare, and this is a cause that deserves the similar kind of discourse, the similar kind of impact reporting, and the similar kind of attention. When we talk about collaboration, you asked me about collaboration. I think from day one, we've also realized that as a single organizations, there is very limited role that we can play or a contribution that we can have unless we make it a collaborative effort. And we've seen this in other spaces, education, healthcare, where when things have happened collaboratively, the voices have amplified and it's resulted in significant changes, which is a much larger, impact than what is the sum of parts. So if funders can align on common goals and what they would like to achieve as a group, I think there is significant merit in that. I think one research excites us extremely in this space, especially because there's such limited research that we do have that is contextual and focused on issues that are very India specific. And that's how, our partnership with GHU took effect, to be able to kind of bring the research rigor in the way the work that we hope to do. And local healthcare systems, I feel, for us, I don't think we can have the kind of penetration that government healthcare systems have today. And a key role that I genuinely see the primary healthcare system being able to enable is to create awareness. There are so many myths, there are so many, misconceptions around this entire space. The kind of networks that an ASHA worker and an ANM can have, I don't think a single organization can have. To be able to kind of bring in the community buy-in, working with local healthcare systems is crucial in any work that we do. So yeah, I think there are multi-levels of collaboration that we hope to have as we work on this space. We're fairly young in this journey, but we genuinely know that it has to be a collaborative effort.
Thank you, Thomas, and thank you for doing this important work to bring this aspect to the field of palliative care. I turn to you, Dr. Bhavna Seth. You are Assistant Professor of Medicine at University of Pittsburgh and Director of Global Health. You have come from state of Pennsylvania to be here, and my question to you is, what elements of United States palliative care training program could be adapted to strengthen physician and nurse capacity in India? And are there patient cases or collaborations that have shifted your understanding of culturally responsive palliative care? And any other aspects of important work that you are doing, I invite you to share.
Thank you again for inviting me to this esteemed panel. Firstly, I was in India this winter and got to attend the National Palliative Care Conference. And I must say that India is in great leadership when it comes to the movement to care and leading it. And I would hesitate. I think that, the US system is very different. And palliative care is a very contextual difference. So things that may work here will unlikely translate to India, or it is for India to determine how best to implement and adapt certain principles in the context of the varied system that it is. And so for me as an intensivist, palliative care comes across as two things to me. It is one, the alleviating of suffering, of all types of suffering, and then also good communication, appropriate communication, which may be breaking bad news or difficult communication or end of life communication, but all types of communication that we do in healthcare normally. And to think of suffering and thinking of communication, this is the role of any healthcare provider in any field, regardless of what lens you're coming up from. So the idea, and just as Dr. Rajagopal said, where this needs to be integrated at every level, we can't bring it as a fringe bolus at the end of an extra sort of feather on your cap that you're a palliative care physician, because this is the role of everyone in health. But how do we...
Let me just pause. Such important point that you're making. This is palliative care needs to be embodied by all healthcare providers. And perhaps I may extend it that palliative care needs to be embodied by all human beings. Thank you.
Yes, how to do this? And so I'm very excited that we've got educational modules that have come into the framework. So you're trying to add on, you've already built your mental models. How do you approach a patient? How do you approach a difficult situation? And so it's hard to retrain in that thing. And so really catching everyone early and building the bricks up from the bottom. But in that role modeling, how to also role model bringing the multidisciplinary teams. As everything in healthcare, it can't be done alone. I can bring in the ICU elements, and half of my work is palliative care in the ICU. But suffering, when you think of suffering, is multifactorial or multi-ranged. You've got suffering from spiritual needs, and we have the equivalency of what we have here for chaplaincy service in the Indian context. And when I visited, there's lovely groups who are doing work of bringing various holy waters, bringing faith-based leaders. And I've had patients here where we're often in a struggle of how to move forward with care. And we've brought rabbis, we've brought other faith-based leaders that patients lean on. The clinicians decide what to do. Suffering comes in the form of mental health suffering. So we need mental health providers for that element. Suffering also comes in the sense of social, cultural, and economic. We've been talking about catastrophic expenditures related to health. And India does have really remarkable social support systems, but many, we don't know how to navigate them. We don't know how to get them in a timely fashion. And here in the US, we would shepherd this to our social work team. So how do we build those ancillary services to address all elements, right? To provide universal healthcare? I see palliative care, while it is a lens for offering relief of these elements, it is also a mechanism of delivering all care through that full lens.
Thank you so much. This has been a really inspiring and energizing conversation that we had about palliative care. I'm also seeing our next panelists lined up here for the next session, but I want to take a minute to see if I can take at least one question from the audience. So if you're inspired to, or if you want to raise your hand, and I will walk to you. Yes.
Can you hear me? So the mainstay of palliative care that I know of is the pain management of the patient. Like they are excruciating pain, and to control that we sometimes need opioids and all. And you get them in India, you can get a firearm easily, right? And how these some with that, because you go to a med store, you can't get them even with a prescription. So you would have to, and sometimes they'll be like, it's Thursday, it's Friday. Our team will sit on Monday, and then we'll decide that if you need it or not. And for those 3 days, the patient is screaming like crazy. And how to we control that? It's very, very bad to see the families and people suffering because of just a drug we take really means. They aren't gonna use it for they aren't gonna abuse it. You're right. So we should have some laws to have them provided on time and easily. Okay, sorry. I'm Dr. Shreyas Mishra, MBBS from India, and I'm here at Observership at Jefferson and Kennedy.
Thank you very much for this important question. And we need more sensitive physicians like you who are aware of and suffer with the patients with uncontrolled pain. And I want to move to invite you, Dr. Rajagopal, to quickly answer this question, if you may. Thank you.
And Dr. Mishra, your empathy and your suffering when you see patient suffering is so obvious. May your tribe increase. Dr. Mishra, we need a balance, obviously. We do not want morphine to be available in every pharmacy in the country, because we would be repeating what the mistake that happened in USA after the turn of the century. When after pulling a tooth, somebody walks away with 3 weeks supply of OxyContin. Now, that doesn't make sense, and it has created a problem. Fortunately, Dr. Mishra, India's current law is much better than it was till 2014. It can be available in any healthcare facility, not in a pharmacy, even in a pharmacy with the drug controller's permission, but mostly in any healthcare facility, if the institution has one doctor with some training in pain management. Because unfortunately, till now, till 2019, medical degree did not come with pain management training. So if there is one doctor with pain management training, you can get from the drug controller the certification as a recognized medical institution. And then for opioids of the step 3 of the WHO ladder, there will be no restriction, except that you will have to make proper documentation. The problem, Dr. Mishra, is that some states have not implemented that. Or even when they had implemented it, a new drug controller comes in and fresh changes are made. That's when we have to be advocates. Like Dr. Mahadevan did with one meeting, the problem was sorted out with a revised order.
Thank you very much for this important question. And Dr. Rajagopal. Yes, and we are going to invite Dr. Carolin to words. Yes.
I just want to add what Sir said also. One more process is, suppose you're not getting morphine also. There are so many things that we can do. Like patients, the pain at the last stage of cancer, many of these things, the concept is a total pain, so that they feel abandoned, not so, counseling. Even in the stepladder pattern, when you take, you can have all other than morphine which is available. So when you look at the patient, you address the need of the patient and also give what you can till there is so much thing still can be done. Like Sir and Ma'am, like big battles is still take time for each of it. It's a contextually, our country is very complex, but still like there is so many things that you can do. So it's like one more thing I want to add again, as Bhavna was saying, that everybody has to be oriented, all doctors, all nurses to be oriented to palliative care, because another problem is revenue, right? For many of the private, I come from private sector. So other than this, another important factor is when you shift a patient from the curative to palliative care, there is also loss of revenue for the hospital. So what happens, that's the elephant in the room. So like what happens is that you would sell hope, saying that, yes, this would become better, this would become, so you, the way, the semantics. So when you say that it's like last 3 to 4 days or a week's time, patient would be like almost, 10 to 12 lakhs of rupees. So people, and also you would play, guilt, okay, you want to give this and give more days to your father. So then you're at like, you'll go and take money and then do this whole thing. So we have to reorient, and like as Bhavna was saying, that empathy, we'll have to, and say that you can do all other things, but the last days of life, we all need to be humans as us.
Thank you. Such an important closing remark. Do not underestimate the power of your caring presence. No more can replace that. And we will end at this. And so happy that we have a house full of people, and we additionally had dozens of people joining by a webinar. This conversation. Thank you all, and we'll be around.
Thank you.
Thank you.
Thank you, Dr. Rajagopal.
Lovely. Thank you so much.
Yeah, they say, like, but it's squeezed in. Yeah, yeah. You're the culprit. Why would